Welcome, Gyno-Curious listeners. I am Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. Today, I am speaking again with Dr. Lisa Curcio, surgical oncologist and breast cancer specialist at Northern Dutchess Hospital, part of the Nuvance medical system, for part 2 of a conversation about breast cancer. I had the opportunity to speak with Lisa in a previous episode about the disease and her own journey with the diagnosis. And she was so forthcoming and shared so much of her own experience that today I thought we would welcome her again. Welcome, Lisa. And that we'd focus a bit more on what our listeners might be interested in as well in terms of lifestyle issues, prevention, risks, treatments, the kind of questions that you and I get all the time in our office. So the current statistics based on the National Cancer Institute is that women in their 30s have a 1 in 227 chance of developing breast cancer. In comparison, the risk for women in their 60s is 1 in 28. And the overall lifetime breast cancer risk for women by the time they reach their 90s is about 1 in 8. So we spoke about a lot of different issues last time we spoke, but I'd like to just reiterate, what are the risks that seem to increase the risk of breast cancer in women?
Well, that's a great question, and I think a lot of people don't realize what those risks are. First and foremost is being female and having breast. More women get diagnosed with breast cancer by a very large factor than men. Men have breast tissue too, but they have a small amount of breast tissue, so their risk of breast cancer is much less. The second, probably highest risk is having a family history, particularly in first-degree relatives, and particularly at a younger age of onset. Usually we consider a younger age of onset premenopausal breast cancer diagnosis. And if there is a history of bilateral breast cancer, that is a significant risk factor. So family history, having breasts. And then there are what we consider non-modifiable risk factors, like having your period onset at a very young age or having menopause at a later than average age, because that's a longer period of time that your breasts are exposed to your high-level premenopausal hormones. Never having had children or having your first child after the age of 35 are also risk factors. Having dense breast tissue on a mammogram is a risk factor. And that's different than having dense breast tissue on exam. Some people feel like they're dense on exam, but actually mammographically, if we identify that the patient has dense tissue, that is a risk factor. Having a biopsy that has atypical cells is a significant risk factor. And actually, the number of biopsies you've had throughout the course of your life is a risk factor. And people can misinterpret that in that a biopsy causes breast cancer, but it's not a causative. It's the complexity of your breast tissue requiring a biopsy that raises the risk. And that kind of goes with the idea of the dense breast tissue, more active tissue. And then prolonged hormone replacement therapy, something that you sometimes prescribe for patients to get them through menopause. But we did have a period of time where women were going on hormone therapy for very long periods of time, like after they go through menopause till they die. And we know now that is a significant risk factor for breast cancer.
Great. And I just want to add the other issue is somebody who had childhood non-Hodgkin's lymphoma who was exposed to radiation, right?
Correct.
Yeah.
Correct.
So you brought up several issues that I'd love to talk about. The issue of dense breast tissue. So women will often say to me, hey, is it because they can't see well through the mammogram that my cancer came about? Or is there something intrinsic to the dense tissue hormonally or cellularly that increases that risk? Do we know the answer to that?
I don't think we have strong data on that. I think we have a kind of firm theories about why that is. Number one is important thing, break that apart a little bit into several segments. Having dense breast tissue is a challenge to diagnose breast cancer, but I think we're getting better and better with our technology. And I think modalities like three-dimensional mammography, or the other term for that is tomography, What that does is instead of just getting 2 views of the breast, it actually takes the breast and cuts it into slices like a CAT scan does and allows us somewhat to see past the density. So I think we're getting better and better technology. And we do know that women who have dense breast tissue benefit from an ultrasound in addition to a mammogram. So I think it's not that we're missing the diagnosis in most of our dense patients. I do think that it is a function of more active tissue versus the stromal tissue, which is the connective tissue in the breast. There's just more active breast tissue that is busy doing what breasts do. So I think that's in part what causes the dense breast tissue to have be an increased factor.
So can you explain to me, because something that actually confuses me is that in my reading, my understanding is that as we age, our tissue becomes fattier, which means to me a little less active hormonally. And yet those statistics I read earlier, it sounds like as we get older, our risk for breast cancer increases. Can you help me understand that difference or that way of thinking?
So I think they're two related things. I think with all cancers, our risk goes up as we get older because the longer our cells are dividing, the more likely there is in error. Now, that's a very true fact that most of us, particularly when it comes to our breasts, but probably other body parts too, as we get older, we have more fat in our breast tissue. But that doesn't happen with everyone. And there does seem to be somewhat of an ethnic predisposition or familial predisposition in that way. For instance, women of Asian descent tend not to get fatty breasts as they go through menopause. They tend to keep their breast density. So it's not uncommon to see someone who's 70 of Asian descent who has breasts that if you just looked at them, you would think they were a premenopausal woman. And there's also tends to be a familial predisposition. I want to also bring up the point that most young premenopausal women do have dense breast. So I don't think it, I think we have the challenges with imaging and we have to look at 3D mammography and ultrasound. But I think more of the risk factor is as the risk goes up based on age and we don't lose our breast density as we get older and we go through menopause, that's really where breast density really plays a major role in breast cancer risk in addition to age.
Great, thank you. It's so important that our audience understands that because so often women come into the office and they've been told they have dense tissue by the radiologist and an ultrasound is indicated. And the first thing they jump to is, I'm going to get breast cancer, right? And I have to describe to them or help them understand that it's not just one variable, one, and two, that our breast tissue does change as we age. So again, it doesn't mean you will get breast cancer. It just means that it is one of those risk factors that we are trying to better understand.
Correct.
The other thing, if you could articulate, what's the difference between family history and genetics? Because they're two different things. We spoke a little bit about the BRCA gene testing last time we spoke. And can you clarify for our listeners how they're different?
So, obviously, family history is what happens with the people in our prior generation and maybe several generations removed from that. And I think that's a really important factor that I would love to try to emphasize to people. It is really important to know as much as you can about your family history, because not just with breast cancer, but with other diseases, we know that there are hereditary predispositions. So the more you know about your family history, I think the more you can find out about what your risk factors are and be preventative for certain disease processes. So I think that when we first started doing genetic testing, that we had these women who had family history. And initially, when we started doing genetic testing for breast cancer, we identified 2 genes, BRCA1 and BRCA2, and they were felt to be the only genes that were associated with breast cancer risk. And yet we had a lot of women that did not test positive for those genes, yet they had these significant family histories. So we said, well, there's genetic and there's familial. But the truth be told, I think familial, and now that we're testing sometimes over 60 genes that are associated with breast cancer risk, we're finding some of those people that are in the familial category have gene mutations, but those gene mutations don't penetrate as predominantly as the BRCA1. So, they used to talk about it skips a generation. And it really, people used to say, I think breast cancer seems like it skipped my one generation and I got it from 2 generations ago. But that's not the reality. Is it has to be, it's a broken gene that has to be passed down. But some people never develop the cancer if it's what we call low penetrance gene. And so it looks hidden in that generation next to you. But the reality is it was there. That person just never developed the cancer, but they had the gene that they passed on to you. So I think a lot, as we're understanding more and more, and I still think we have these patients with significant family histories that we test them and we haven't found genes. And now we're doing RNA in addition to DNA that's picking up some of those gene mutations. So I think a lot of what we look at as familial will be genetic mutations as we more and more understand how our genes work and how they interplay with the proteins that we actually make. I think there are a small percentage of people that have familial cancers, and a small percentage that might be related to where they grew up, exposures during early childhood. And we know, just like with radiation for Hodgkin's disease, exposures when your breasts are developing during those formative years that the breast tissue is developing can set the stage for cancers 10 or 20 years later.
Certainly, we have maps of areas in this country where breast cancer incidence just seems to be much greater than other parts of the country. Yeah, for sure. I want to speak to the women who come into my office who say to me, I don't need a mammogram. I have no family history of breast cancer. And I can't tell you how many times I say to these women, well, let me tell you that really maybe only 5 to 10% of all cases of breast cancer are due to hereditary factors as far as we know right now. So again, I want to just point out to the audience, just because if you've been blessed with a family history of no breast cancer, unfortunately, it doesn't mean you don't need screening or be aware of what this disease looks like and how to test for it, right?
Correct. I just have one statement that I would say to a patient who says that to me. 75% of the patients we diagnose do not have a family history.
Yeah.
So there are other individual factors. The other thing that's important also to take into consideration is when you come from a small family, like mom was an only child, dad had one brother. So there's not a lot of females in the family to actually demonstrate or exhibit that predisposition. And then we have more and more people that come from backgrounds where their whole paternal side is estranged because dad wasn't present and they never really got close to that side of the family. So there's a lot of factors that play into that no family history that when you sit down, and I can't tell you how many patients come to my office and when they initially fill out the paperwork, they say there's no family history. And then we sit down with them and say, okay, mom's how old? Does she have any cancer? Dad's how old? Then we go, okay, dad's mom and dad. Well, are they alive? Are they dead? What age do they die? And go back 3 generations. And we find cancer risk in those families. It's just they don't think about all those family members, especially if they particularly died young. They just get forgotten in those families.
And moreover, in those generations, often there was no conversation about what was the cause of death. Autopsies were rarely done. Women, men, everybody was dying at a younger age, partially because of what was going on just in the communities at that time. But certainly the taboo around illness was so heightened and there was so much shame about illness. So cancer was rarely talked about.
And female cancers in particular
For sure.
were not discussed. They were suffered in silence and really not discussed.
Yeah. So as you pointed out, most breast cancers occur in people who were assigned female at birth. However, people of all genders can get breast cancer. So for example, if you're a transgender man or a non-binary person, you can still be at risk. So this is even true for folks who have had top surgery. So I want to just point out again that people who are assigned male at birth can also get breast cancer. So can you just speak a little bit to our audience who may be in transitioning or transitioned or non-binary about how you would speak to them about breast health?
So I think male or female at birth, we all have breast tissue. Obviously, A female who has top surgery, oftentimes it really depends on who's doing that surgery and how much breast tissue is left behind. But even myself, as a breast cancer surgeon, when I do preventative surgery for someone who's at high risk for breast cancer, like with a gene mutation, we know that their risk never goes to zero. And a lot of times people do want to do something definitive and not have to worry about that part of their body again. But the reality is, even the best surgeon in the world, there is some microscopic breast cells left behind. And depending on who's doing that surgery, it can vary dramatically. So I think that's really important. And then we certainly don't have long-term data about people, particularly if they're placed on hormone therapy at an early age, what the long-term risk is on cancer in that population. So I think that's something that only time is going to tell us, because it's relatively new. I mean, it was done, several decades ago, but in small numbers. And we just don't have large numbers to actually have the data available.
And I want to point out that we're talking about both estrogen and testosterone.
Correct.
That the science about using these hormones long-term for transitioning is not the same as using these hormones for, let's say, hormone replacement therapy in the vulva haver who is using it postmenopausally for her hot flushes, for example.
Correct.
Very different communities. So a conversation that I have way too often in my office, and it's such an important one, is, as a gynecologist, I'm talking about vaginas all day long. You're talking about breasts all day long. And there is an area in which we sometimes conflict, and that is about vaginal estrogen. Mm-hmm. So I'd love to talk about that, because it's such an important one. And we touched a little bit about sexual functioning after surgeries for cancer, but particularly breast cancer last time we spoke, and the changes that can sometimes happen in our body as a result of the medications that we take for chemoprophylaxis or chemotherapy. So there's so much to talk about, but what I want to focus on is the woman who comes in who either is at risk for breast cancer because mom, sister, aunt had breast cancer, which is one population, but also the woman who has had breast cancer, who comes in who says, I am no longer having penetrative sex. My vagina feels like there are chips of glass. My relationship is falling apart because my male partner is wanting to have intercourse. What do you say to them about vaginal estrogen, please?
So
it's a tricky subject. It's very tricky.
And I think we may differ a little bit on this.
That's
concept.
okay.
Hard and fast, particularly if the patient had an estrogen-sensitive breast cancer, we generally try to get away from using vaginal estrogen. Now, there is some recent data on DHEA, which has been very promising. The only issue with DHEA is if someone's on an aromatase inhibitor, which is a class of medications that inhibits enzymes that convert DHEA to estrogen. If there's systemic absorption, we can, then if they're on those medications, it would be negated because the enzyme's no longer active.
I'm just going to interrupt you for a moment. Please tell the audience what DHEA is, please.
Dihydroepiandrosterone. It's a testosterone precursor, but in postmenopausal women, it's the primary source of estrogen, and that comes from the adrenal gland, DHEA. And some people take DHEA supplements for libido as they go through menopause. But in postmenopausal women, the primary source of estrogen comes from DHEA, which is made by the adrenal gland and gets converted into estrogen through an enzyme called aromatase. One of the treatments for breast cancer, or one of the preventions for breast cancer, are a class of drugs called aromatase inhibitors. And they actually deactivate that enzyme so the DHEA cannot get converted into the estrogen. In theory, if they're on an aromatase inhibitor, that could be a safe drug. I think a lot depends on vaginal estrogens. This is what I explain to my patient. I think if they go on it early on, like right as soon as they go through menopause, then their pelvic organs are still very well vascularized. So a lot of these people that I see go on vaginal estrogens, they'll get relief of their hot flashes. They'll get breast tenderness and enlargement. and they are having systemic absorption. But I think if you take someone who's maybe 10 years into menopause and now they're having all these symptoms, I think at that point, a lot of the blood vessels that are going to their organs are now shrunk down. They're not working really well. And I think the systemic absorption is a lot less. So I think they're probably in a safer group to use that category of medications if the quality of their life is that adversely affected. But we do try to do non-hormonal means first. And there are now more options available than there were 10 years ago. And there's companies that are actually have a whole line of non-hormonal products for postmenopausal women.
Yeah, in my office, I actually have a list of products that I share with women that are non-hormonal. And often it's really very helpful. I call them moisturizers. So the idea that you use lube when you have any penetrative sex, but that a moisturizer is something that you use 2 or 3 times a week or every night before you fall asleep, not in anticipation of sex, but just to get that tissue moisturized and supple and more elastic. And they can often be very helped by these products.
I think people have to realize that, yes, as we get older, no matter what, I think just like you put moisturizer on your face, you have to moisturize the vaginal area too, because it's an area that will tend to dry over time, just like our facial skin, if we don't moisturize it. I think there's a whole area of sexual health after breast cancer. And I think also there's this disuse atrophy if they're not having frequent sex. And so, I know that there's some people who believe, and I think the data seems to suggest that if they're not sexually active, they should be doing things like maybe dilators or things like that to keep that area supple and used to that kind of activity. So when they do have a sexual encounter, it's not as traumatic. It's use it or lose it. It's like our muscles are that way and our vaginal area is that way too. So I think we do need to be proactive to keep our vaginal health as we get older, and particularly if we're taking medications that lower our estrogen levels.
Yeah, for sure. And it's a conversation that's often very difficult for women in my office. When I start speaking dildos and dilators and vaginal moisturizers, there's a very large cohort of women who have been raised without this language, without this knowledge, who don't know how to go on the internet to type in sexual products. So it's an area that is so important for you and me and all of our colleagues to be having and to have their own facility in the language, because it's not just that patients don't want to ask about it, but far too many of our colleagues, as we spoke about the last time, aren't willing to talk about it because of their own personal stories and journeys around this issue.
Right.
Yeah.
And as we talked about last time, if you don't ask the patient the question, they're not going to volunteer that information, particularly our breast cancer patients. Sometimes I think they feel like they just need to be happy that they're still doing well from their breast cancer, and it's a small price to pay not to be sexually active anymore, which is not the case. If we've cured the cancer, but we've destroyed the life or the relationships around that life, then we haven't done our job well.
Right. And I like to say to my patients also, there's a lot of ways of being intimate. And that part of the journey is being creative, communicative, and willing to accept that aging, again, with or without cancer, changes our vaginas. And that the exploration is figuring out what works best for you and your partner.
Absolutely.
Yeah.
Absolutely.
So we're coming to a close, but I want to just briefly touch on 2 issues. These are both screening techniques. One is MRI, which there seems to be some controversy around the use of, and thermography. This is a community where people are often looking for kind of alternative ways of evaluating the breast. And I suspect you've been asked about thermography. So if you could just touch on thermography and then briefly what the role of MRIs are in the evaluation for breast cancer, please.
So thermography is used based on temperature in the breast, and areas that are higher temperature could potentially be problematic, and doesn't necessarily mean it's cancer. And we see a lot of patients who have thermograms outside, and we do standard imaging and we don't find anything. So I think there's a lot of false positives. I have seen cancers diagnosed with thermography, but these are usually larger cancers that if you did a good breast exam, they would probably be diagnosed also. So I'm not a big fan, and I don't think there's a lot of solid data showing that thermograms are a good screening modality. We know that mammograms are the best test to screen for breast cancer. And we also know that a breast cancer diagnosed with mammogram only, if it's not felt, has over a 95% survival rate. So it's the best way to diagnose breast cancer at its earliest stages. In terms of MRI will never replace mammogram. MRI is a test that's used to give supportive data to mammogram and ultrasound. We particularly use it in our high-risk patients, someone who has a gene mutation or strong family history, and it looks at blood flow. So we give a contrast and it goes to normal breast tissue. It goes quicker to breast tissue that has increased vascularity, which in the majority of cases tends to be cancers or areas of maybe precancerous changes. And so based on the difference between the background enhancement, we can pick up areas more carefully. In terms of it has a very solid place in screening for high-risk populations. So anyone who has a higher than average breast cancer risk can be a candidate for breast MRI, but they have to be at a certain level of risk for a lot of private insurances to allow us to get MRIs. In terms of MRIs for breast cancer, I think there are different philosophies. I practiced for 20 years on the West Coast, and we used MRI extensively. We were early adopters. We had excellent radiologists, and we used MRIs in every breast cancer patient. And we found other cancers at the same time that one was diagnosed by mammogram, because MRI could probably pick it up a couple years prior to a mammogram detected lesion. So, but I think on the East Coast, there's more of a selective use of MRI. And even my society only advocates it in certain circumstances. I think my experience and my current practice, I use MRI pretty extensively. And sometimes we do diagnose several cancers. And I think it saves the patient the trauma of having one cancer diagnosed that's detected on mammogram, only to maybe 4 years later get diagnosed with the second breast cancer.
So what I'd like to point out to our listeners is if it's being recommended you have an MRI, please speak to someone like Dr. Curcio before perhaps you have it so that you can better understand how it impacts your overall health, what kind of screening technique it is, how it may in fact pick up several cancers, and that it's not for everyone. It is not a routine screening test.
No. Okay. No, it'll never be that.
Yeah. Lisa, I can't thank you enough for joining me again. I'm curious. It's such a pleasure to speak with you. You are a vast wealth of knowledge and experience. So thank you for sharing.
Thank you for having me.
Thank you also to my listeners for joining me as we venture into the limitless conversations about our bodies and the world of OBGYN. I would love to hear from you. Please email your questions and comments to comments@radiofreerhiniecliff.org or call us at 845-307-7446. Also, thank you to my producers, Jen Hammoud and Matty Rosenberg. Until our next conversation, stay healthy and stand strong in your knowledge and your insights.